All right. Welcome, everyone. Thank you so much for joining us. We're really excited to share our first YouTube Live. My name is Jess Liedke. I'm a COVT. I've been working with Dr. Juanita Collier here for a long enough time. And we work with Dr. Collier's brainchild, 4D Vision Gym. And we're going to talk a little bit about what we do to work with other practice owners. But today, we are talking about the value of vision therapy. We all know it changes lives, or rather, we're not talking about the value of vision therapy. We all know it changes lives. Instead, today we're going to look squarely at something a lot less discussed. That is why the very practices delivering this life-changing care often struggle financially, even when demand is strong and outcomes are excellent.
So today we're asking the question, how did my dream become my job?
Yeah. And to illustrate this point, I'm going to share a story that is very likely familiar to some of you who are joining us tonight. Imagine Dr. Morgan. She opened her vision therapy practice young. She was in her early 30s. She was passionate, idealistic, and deeply convinced that this work matters. She didn't come to open a practice to build a business. She opened a practice to change lives, to create access to care that she believed in, and to do vision therapy the right way without compromise. And at first, it felt like success. She had referrals out the ears. The patients were grateful. Progress that no one else had been able to unlock was happening in her walls. The schedule filled quickly. The demand kept coming. And from the outside, the practice looked very busy and respected and thriving. But beneath the surface, something wasn't quite adding up. The vision therapy arm of her practice wasn't actually making money. Reimbursement rates changed, insurance codes shifted. What had once had been predictable became inconsistent and opaque. Each adjustment required more documentation, more justification, more time, often for less return. Sessions took just as long, outcomes were just as strong, but revenue no longer reflected the work that was being done. And at the same time, patient expectations were changing. Families needed evening appointments, weekend options, flexible schedules, payment accommodations, more communication, more reassurance, more customization. Each request made sense on its own, and Dr. Morgan said yes to most of them, almost all of them. Because access mattered, and because people needed help, and because that's what good care looks like. So the practice adapted. Dr. Morgan stayed later, opened more time slots, took on the hard cases, answered all the hard questions, all the staff questions, all the patient questions, handled every exception, and filled every gap. And the vision therapy program became increasingly complex and increasingly dependent on her. If a patient had a concern, they wanted Dr. Morgan. If a therapist had a question, they went to Dr. Morgan. If a decision needed to be made, it waited for Dr. Morgan. And still, the numbers didn't improve. The practice as a whole looked successful. The waiting list stayed full. The mission was intact, but the vision therapy arm quickly and quietly drained time and energy and margin, while demanding more of a doctor every year. And Dr. Morgan worked nights and weekends, charted after dinner, took calls between school pickup and bedtime, missed school events, not all of them, but enough to feel that sting and to feel the trade-offs beginning to stack up. She was exhausted. Not burned out because she didn't care, but burned out because caring required constant personal sacrifice with no structural support underneath it. And the hardest realization, she wasn't failing, she wasn't inefficient, and she wasn't doing vision therapy wrong. She was operating inside a model that required the doctor's time, presence, and availability for the program to function, while external pressures steadily eroded its financial viability. Her dream hadn't collapsed, it had simply become unsustainable. And that's when the real question emerged. Not how do I fix this, but is the way I'm delivering vision therapy the only way it can be delivered?
Now, I'm sure many of you, like me, feel personally offended by Dr. Morgan's story because
I
it
didn't
sounds
come here to
like
be attacked.
exactly. I feel like that's Dr. Collier's story, but interesting. But, like that's kind of what a lot of us are going through. We came into this because this was our dream. Like we have the secret to life in all honesty. Like we can change how people see the world. Like not many people can do that. And then we have that certain feeling of an obligation to do it as well, because we have this ability to help everybody. So that means that we also need to help everybody. And that's kind of what we want to talk to today, because we want to make it so that all of you can help everybody like we are set out to do without actually feeling like we're burning out and we're losing our minds and that it's not profitable. So that's why we're here today.
Because the reality is that most clinicians don't burn out because they're bad at what they do. They burn out because their expertise is trapped inside a model that requires them all the time. So think about all the work that you put into work on the business versus the work in the business. You've got your patient questions, your staff questions, the scheduling questions, the treatment questions, report writing, supervision decisions, referral outreach, relationship building, vendor orders, you name it. You're dealing with it. And oftentimes, doctors think, I'll just hire more staff. I'll just tighten up the schedule. I'll cut costs. I'll be stronger in my boundaries. But these tactical fixes, not the structural ones, they don't really get at the problem. Because if the fundamental system ties all revenue growth to the doctor's time, then volume gains are limited and your stress increases. So, one thing that we are going to talk about is not that, doctors work too much. I mean, that is a thing, right? If you work too much, you could get burnt out, but it doesn't actually come from there. It comes from working in the wrong zone of your genius for too long. Because if you could think about it, there's a frame of thought that there are 4 zones of genius in which we can really work our expertise. There's the zone of incompetence, which is the places, the things that we should not be doing because we're not good at it. It's not efficient for us to do. You should not be spending your time on those tasks. And then there's the zone of competence, which is stuff that you're pretty good at, but it's not the best use of your time. Those are the things that you could be doing because it's, effective, busy work. You could work with, the schedule and making sure that everyone has an appointment time. But that's probably not your best interest, best place for you to be as a practice owner. That could be delegated to someone else who could handle that very well and would be a better use of their time. Now, incompetence and competence aren't really the issue. Excellence is. And the zone of excellence is the real trap. This is where most of our successful clinicians get stuck. You're excellent at care delivery. Your team relies on you. Your patients want you, but excellence doesn't scale. It creates dependency. And dependency turns the owner into the bottleneck of all the things that need to happen. What the zone of genius actually is, and this is the kicker. This is where you want to be living.
This is where you should be all the time, as much time as possible.
Your zone of genius isn't in delivery, it's decision making. For practice owners, That means setting your clinical standard, designing how care is delivered, teaching once instead of repeating and repeating and repeating. It's making strategic decisions that change the trajectory of the practice, because if your practice can't function at a high level without you being everywhere, you're not operating in your zone of genius. You're subsidizing the system with your time.
Exactly. So, when I first opened, I trained every therapist and it was great. And every therapist knew exactly what I wanted them to know. And they practiced exactly the way that I wanted them to practice. And then we got bigger. And then we had like 10 therapists. And then we had 150 vision therapy visits a week. And, my therapists were training my therapist. And it was like this game of telephone. And things got a bit out of hand. And so then I had to step back and say, okay, my zone of genius is coming up with how I do vision therapy and really making sure that people understand how I do vision therapy. However, I can't repeat to every single person who works in this practice how I do vision therapy. Like, that's actually impossible, especially since I might have been Dr. Morgan that Jess was talking about earlier. So, between pickups and everything like that, I'm on calls. I'm trying to, put out fires and all of the things. And so there was no way I could train everybody. And I didn't want the quality of care to go down. So what I realized is that there has to be a way for me to be able to deliver what I do all the time consistently so that everybody else can deliver what I do all the time consistently.
Exactly. So what actually changes that, right? If it's not working harder, if it's not better boundaries, if it's not another hire, it's definitely not more motivation, because if these things would have fixed it, it would have been fixed by now, right? There is actually a way to increase your profitability that doesn't require more of you. Dun, 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 dun. Your future practice will likely always include in-office vision therapy. It will, but it cannot rely on it alone, because this is what changes when digital becomes part of the delivery model. Patients get consistency, teams stop improvising, you stop being the bottleneck, capacity is protected, and revenue is no longer tied to more visits. This isn't about replacing in-office care. It's about making sure in-office care is no longer carrying everything.
And like Jess said, we always are going to, if you're like me, we're always going to want to do in-office vision therapy, because there are certain cases, especially like the tricky ones, where you're like, okay, like I need to get my hands in there and I need to know what's going on exactly. I need to know exactly what happens when I put this flipper in front of them. And so I get it. I know we're the same. And also, there are some cases that we don't actually need to be hands-on for. And we know how to train therapists. That's what we do. We know our special way of delivering vision therapy. We know what change vision therapy can make in people's lives. So how can we deliver this at scale without having the doctor burn out? And we also know so many of our peers stop offering vision therapy. So, a lot of people graduate and they're like, oh yes, I want to have some vision therapy in my practice. And then as time goes on, that starts to fade away. And then it goes into just like implementing some tools, like HTS is a program that we still use for homework for some of our patients. And, we'll probably use it forever. It's great for maintenance and things like that. But a lot of our peers, as you know, have gone to just having that be the only vision therapy that's offered, because it's just not sustainable to offer that one-on-one care in your practice, because vision therapists usually get paid more than technicians. So, they're getting paid a lot more, and they're also needing to do one-on-one or one-on-two care, whereas a technician can see a lot of patients for you in a short amount of time. And so when we're looking at just like the profitability of payroll there, the line item for payroll is so much higher in a vision therapy only practice. And so, then we have to kind of offset it. So a lot of practice owners that we work with say that the rest of their practice is funding their like hobby of vision therapy, or like, they really love vision therapy so much that they need their dry eye practice to fund it. And that's not sustainable. It's not a great business decision. And it's because we have such a strong desire to offer this care to our patients, but how can we do it while also making a profit? How can we do it? How can we make this impact without having, this be a drain on our practices?
And we hear a lot of other practice owners saying, "Oh, we tried digital. This, like we've done digital before." Or we use HTS as our at home. And we get it. Like Dr. Collier said, we use them too. But that's not what we're talking about. Our digital delivery model actually has a structured patient journey. This is clinician guided progressions that embed education as well as explanations so that your experience and your expertise comes across consistently. And it doesn't matter who, actually gives access to the program, your model continues to every client, every patient that you have. And it's designed to scale without dilution because you can actually, give the same care over and over and over again with a different infrastructure than when the only tools you had to be able to offer were different kind of apps or programs that were just kind of like piecemeal or homework assignments or PDFs or even the videos and different portals with those homework platforms. There's a place for those. Those are great for your in-office patients, but they are still very customized or so generic that patients aren't getting the real benefit of your delivery of care. They're getting very fragmented care.
Exactly, because, when we use those digital programs, when we use, back when it was Binovi and now it's Neurovisual Trainer, it's great because all of the videos are there. And so it's, super, as far as from the doctor's perspective, I'm like, oh, this is amazing. Now our patients are going to know how to practice. But as from the therapist perspective, it seemed like that wasn't so great. So, Jess would
my Brock string has a red, a green, and a blue bead, while the one on the video is a purple, a yellow, and a teal bead. Can I still do Brock string?
Yeah. So, it was a little bit tricky. And so and then what needed to happen is after every session, our therapists were going in and programming things and needing to kind of like stay late to make sure all the videos are there and that all the instructions are in line with what our instructions are and everything. And then when they would come in for their next session, we would have to redo that all over again. So it wasn't actually saving the therapist's work. And then a lot of times patients don't do the homework anyway. So then the therapists were like, I did all this work, put all these videos in, you need to practice. So it was like a whole situation there. But what we realize is that if we can kind of bottle up what, our IP is and how we would treat certain conditions and how we would get patients to their goals that they're coming in for, and vision therapy became more goal oriented than diagnosis oriented, then the patients were much more bought into the program. And also we were teaching them the methodology behind it. And so that's how our digital delivery method actually kind of took off, because we were really diving into why they were here, why they were coming in. And that's not their ocular motor skills or their accommodation or their binocularity as much as we want it to be. That's not what patients care about. They care about, can their child read better? Am I driving home without headaches? How long can I be on the computer? How efficiently can I work? All of those things. And so then we created programs that really focused fully on that model. And how do we get what we do in the office to translate to their home in a package where it's really how we would treat them specifically, with all of the explanations, with them understanding what's going on, with them understanding how to load, how to unload, what to do if you're not feeling well, what to do if you have a headache currently. All of those things we were able to put into one model. And so it really went way past using the tools and really going into, now this is how we do vision therapy. This is how you're going to get from point A to point B. And this is how you're going to really be able to take control over your vision. And that's what we want for our patients. That's why we're doing this. We're empowering them to understand that they can see the world differently than they see it now. And we're through a digital delivery model, we're able to make that even more plain for them, because now they're really able to take control and they're getting the explanations the way that we want them to be conveyed. So that's kind of how we stumbled upon this digital delivery method.
And that brings us to our vault. The vault is a fully built clinician guided patient journey delivered digitally. So we have developed programs for basically the entire lifespan. And it ended up, it started because, out of necessity. When we shut down during COVID, I'm sure many of you probably had very similar experiences, and we needed a way to be able to continue care for our patients. And we ended up going digitally, trying to do the therapy sessions over Zoom, trying to, I'm sorry, it was terrible. And I'm sure many of you can relate, right? And then we started to open back up, but then of course we had wait lists, and because we were, trying to maximize our time, and we had to sanitize even between every patient, like everything, and we had to air purify every room, and there was just so many things. So in order to serve as many patients as we could, we started with our first digital program. And that was our program called 4D Built to Read. And we designed it for children ages 6 to 9. And we thought, okay, this is a way that we can kind of get them started, give them a taste of vision therapy by going back and treating the foundational causes of the most common visual developmental delays that a lot of our kids were presenting with. And it didn't matter if it was CI or CE. It didn't matter if it was an ET or an XT. Like, we just needed to get at the foundation.
Yeah,
exactly. And so we thought, okay, this will hold them over. And then once they can come into the office, then we can start the real therapy. And lo and behold, we cured amblyopia. We resolved esotropia. It worked a lot better than we ever anticipated. But the idea is that we didn't just give them homework to do in the meantime. We provided them with a full digital vision therapy program with education from the ground up, and it works.
We were essentially training. Exactly. We were essentially training the parents as junior vision therapists. So just like, our therapists in our office have to understand what oculomotor is, what accommodation is, like all of those skills, we were teaching to the parents in ways that parents could digest and actually understand. So then they're in the grocery store practicing their vision skills with their kiddos. They're doing it in the car. They're like, they're figuring out how to incorporate everything, because the parent, like, our therapists are amazing and they're angels from heaven. I could not be a vision therapist. That's not how my patients is set up. But therapists are amazing, amazing, amazing people. And parents know their children even better than therapists do. And so once the parents understand why their child is suffering, they really fully get it. And it's not, at like the 10-minute consult that you're doing after the exam, or when you call them back in to go over the report, and, they're probably listening, mostly listening, kind of hearing what you're saying, getting about 25% of it in. And, this way they actually have that content right there that they can revisit. They can explain it to whomever else in their family doesn't understand. They can explain it to the teachers. They can explain it to the coaches. They can explain it to everybody, because now they have this digestible information that they can revisit whenever they need to. And then they also have the tools to work on these skills with their kiddos. And so parents were not only excited to actually finally understand their kiddos, but they knew when their child would be able to practice, how they were going to get their child to practice. It was so much easier for the parents to get it done, apparently, because, our patients who would come into the office once a week and then practice at home would be coming in for weeks and weeks and weeks and weeks and weeks. Whereas when they did the 12-week Built to Read program, now they're seeing 2015 in a 2050 best corrected eye. And that doesn't actually make sense, but it does because we had the parents on our side, and the parents were now the vision therapists. And then once our adults heard that we had this program that was working, they were begging for a digital program because, as you know, some of our head trauma patients, they don't always have a good day when they're coming in for therapy. So, there are some times that our therapists would just sit in a dark room,
become therapists of a different matter.
Exactly. Yeah. And not much vision therapy was going on in that room. And then when they were home, they'd have a great day but barely remembered how to practice. And they couldn't watch the videos because they were getting headaches and things like that and all of that. So we were able to actually create a program for them where now it's like their focus is being able to be on the computer, being able to get back to work, being able to get back to driving. And they could do it when they had good days, which makes a really, really big difference for them, obviously. So we were seeing that patients were getting back to their activities of daily living and feeling normal again so much more quickly than they were in office, because in office they had to work around our schedule. And with the digital delivery method, they didn't have to work around that. They could work around how they were feeling. And then they're back to driving so quickly and they're feeling great. And we had one patient who said that she couldn't sit across the table from her husband when he was eating after her brain bleed because him chewing gave her motion sickness. So at the end, she was like, "You guys gave me back my marriage." Yeah. So things like that we wouldn't even think of, where these people were able to just treat themselves at home and really understand what was going on. And it was still directed by us. And so we were still seeing them for reevaluations. We were still able to be like, okay, so we're going to add in this exercise and this, that, and the other, because your vision therapy doctors, obviously you're going to tweak everything, but the patients could really take control of their own health and their own vision at home.
And I think one thing that I want to hit on with you saying, they couldn't watch the videos, all of our therapy from our digital delivery model is actually done in free space. So the education pieces and the computer-based components are not the therapy. And I think that's a big, big difference between our Vault programs and other at-home digital therapy programs that are so screen-based. Ours is just taking the vision therapy room home. So, they could, even if being on the computer is uncomfortable and, exhausting, at least in the beginning, they can just kind of cue it up and listen. And then everything that they need to do that actually makes a difference is in real life. They have printed out charts. They have real space activities. So I think that's a really huge thing to note, is that we took our in-office experience, but brought it home to their schedule and their lives.
And then to bring this back to profitability, because that's why you guys came in here today, we really want to go into how can that be profitable, because we don't want to be offering, a less expensive form of vision therapy where we're just getting less money, when the concern was that we're not making enough money in the first place. So that's not helpful. So let's go a little bit into profit.
What our programs have actually generated is over $300,000 in revenue.
In only a couple years.
I'm sorry?
In only a couple years.
Only a couple years. And this revenue wasn't created by software. Again, it was created by clinical thinking delivered differently. And that was before we even knew what we were doing, which I love. But each of our programs is priced, kind of more accessibly to families that might have some financial constraints. But the thing is that when we are able to deliver these digital programs from like, $500 to $2,000 or more, then we could give more and more of those programs without us having to do the work. Right? You see where I'm going here? The scalability is that you basically create a clone of your treatment and are able to deliver it to the masses while impacting your bottom line without impacting your effort and energy.
Exactly. And what some of the doctors that, were a little bit hesitant about were like, oh, but I don't want my therapist to feel like they're not necessary anymore, or that they're going to lose their job or something like that. And that is so far from the case because therapists, as you know, burn out too. So, how many amazing therapists have you lost in your practice because they're just exhausted and they don't want to do the hours anymore? They don't want to work evenings. They don't want to work Saturdays. Like when we first opened, Jess, we were open until we saw patients until 7 o'clock at night, every night.
And then we stayed and did our charting and had like a glass of wine and some cheese.
The good old days.
Like unwind, and it was great.
And that's what we're not. Yeah, we weren't. We didn't have kids yet, so we could just stay at work all night, and it was fine. And now we have a lot of children, so cannot. But also, the Saturdays. So patients ask for Saturdays all the time, and they also no show like crazy on Saturdays. So a lot of doctors that we've spoken to are like, so we don't do Saturdays anymore. But then patients complain because there's not Saturdays. We had a patient put in a formal request that we were open on Sundays as well. We're like, okay, we're gonna file that in our in our trash can. Like, stop it, please. Like, we are here all the time. Stop it. And so this just really made it a better experience for our therapists because they didn't feel guilty going on vacation, or they didn't feel like they had to come in when they were like kind of sick, but maybe okay. And like Dayquil might help. Like that's not what they had to do anymore because we just had so much more flexibility for them, which made this feel much more like a career. So, this wasn't something that they're going to do until they burn out and then have to figure something else out. This is a place where they can sit and stay and be happy. And so we once we had digital, we didn't really have turnover anymore. And so it actually made it a better experience for me as the practice owner because I wasn't constantly needing to train therapists and hope somebody stayed. And then are we paying them enough and this, that, and the other and all of this? Because they actually have a real career where they can feel really, really fulfilled and not just like they're running and can't go to the bathroom after 3:30 when school gets out.
Exactly. And it's really what it boils down to is that it gives you so much more freedom, right? Like you don't have to fill every spot every day, every hour, make sure you have enough, in-office patients and then run your therapists into the ground. Digital didn't replace our expertise. In fact, it kind of preserved it, right? It allowed us consistency in our outcomes, as well as just our ability to be fully there and present with all of our patients. Because that scale, it didn't dilute anything. It didn't dilute our value. It just amplified it, which was pretty cool.
And so
go ahead.
What a lot of doctors think at this point is, okay, that sounds great for you. And I'm glad you were able to do that. Yay. And I have no ability, no time, no anything to even consider creating my own digital program. So thanks, but no thanks.
Mm-hmm. And that's fine. We get it. We really do.
We didn't have time either, but I totally get you not having time because we already created it, so you don't have to.
Because we made all the mistakes in the beginning for you. We made them all. We found all the wrong ways to do it, and then we finally figured out the right way to do it. So all of our programs are actually very like well done so that you don't have to. And all you need to do is figure out a way to be able to develop your digital arm of your practice without paying the same mistakes that we did. Without a digital arm of your practice, you're repeating the same explanations, you're inconsistent with your patient follow through, your therapy is dependent on specific staff, you got your growth capped, your revenues tied to your presence, all those things that we've already talked about. But with a digital delivery method that you can just use, you are doing the thinking once and repeating the impact as many times as you want to. You're standardizing your patient experience, which builds the team resilience and continuity. It protects your capacity and it takes away the very intricate relationship between your revenue and your visits. It takes them apart from each other, and you can see the patients that you want to see, not just the patients that you have to see because you need the money. That's not what this is.
Exactly. And as Jess said, we essentially created programs for the entire lifespan. And so we have programs ranging from like our toddlers all the way through our stroke, brain injury, concussion patients, and everything in between. And so this way you can automatically start right away with your own digital arm. You can start building up this digital arm where you're getting this revenue in, you're able to decrease your wait list, you're able to relieve some of that immediate burden on your therapist, some of that immediate burden on yourself, and start making some revenue that can build a little cushion for you so that then, you can really start to serve more patients. And that's why we got into this in the first place. And so this is really the way that we can kind of amplify your impact. You can get vision therapy out to everybody in your community. We have patients who travel hours to come see us from other states because, they heard that they can actually do this at home, because they've heard that, there's a way to do real vision therapy just like they would get in the office and have the same results as they would get in the office, but not needing to come in once a week. Not our head trauma patients not needing to find a ride every single time that they have an appointment. Our head trauma patients, especially after COVID, it seems like our stroke age went down significantly. So we have all of these like 48, 52-year-olds that have strokes, and they're like, I don't have anybody to bring me. My spouse is at work. My kid, I don't want to put this burden on my kids. I can't do it. And so then they just kind of silently suffer and just compensate and figure it out and like semi-compensate. And it's like, oh yeah, I'm fine to drive. And it's like, no, you're actually not. And so all of these things are easily served by the programs that we've already developed. And we didn't want to keep this to ourselves. We wanted to make this as accessible as possible to other optometrists, to other VTODs, because this is what we do. This is why we came into it. We want to help everybody that we can. And since we already kind of went through the work of building these programs, we wanted to make it accessible to you as well.
Exactly. And so that's where our program Built to Scale comes in. It's our ongoing container for doctors who are no longer asking if digital belongs in their practice, but are focused on how to scale it well. So it's for doctors who are actively building or have already built a digital arm and don't want to do it alone, inefficiently, or by trial and error. Because inside Built to Scale, the work shifts from starting to refining. We focus on structure and delivery and systems so your digital arm can grow without creating another version of burnout, because that is not what we're here to do.
At all. At all.
This is the CEO level work about protecting your time and increasing your consistency and making sure that growth doesn't come at the expense of your life or your practice.
So with having a digital arm, you get that ability to, like I said, develop profit, to like really start making more profit, helping more people and all of those things, while also giving yourself some space. And so what some of our doctors call it is buying back their time. And so it's like they're getting time again, so they can step back from their practice, they can look at their practice and see what can they do to tweak things, what can they do to make things more profitable, what can they do to make things more efficient, how can they help more people, and then making it full circle, how do they operate more in their zone of genius? And so with having this digital arm, you get a better quality of life. Your staff gets a better quality of life. Your patients get a better quality of life. This is the way of the future, because patients now are looking for ways to do everything from home. Everybody wants to work from home. Everybody wants to be able to do things on their own terms. And we're kind of still in this, I don't want to say antiquated, but kind of antiquated way of them needing to come in for every single session to get care. Patients aren't looking for that anymore. And if we stay in this way that we used to do vision therapy in the 50s or 60s or 70s or 80s, we're going to not be able to have sustainable practices anymore. And as we see all of our, I don't want to call them elders, but all of the people who came before us who are doing who were doing vision therapy, a lot of them, when they stopped doing vision therapy, their practices just went away. People weren't buying their practices. It's not what's happening anymore, because people aren't wanting to move into these practices. We actually created this webinar because every time that I lecture to students, that's the statement that comes up, like, vision therapy is cool, but I heard that you can't make any money in it. And we want to change that. We want to change that for the people who are practicing currently, and we want to change that for the students who are graduating, because there's such a big need for vision therapy, and we want to make it as easy as possible for doctors to be able to offer this and also be able to breathe.
Exactly. So notice how clear this all looks. It's what alignment does. So we don't want you to leave this webinar with more ideas. We want you to leave with clarity, because clarity changes what's possible. And so if this resonates with you, if this conversation has shifted how you see your practice, we want to invite you to take the next step, which is a 30-minute call, a 30-minute strategy call. Because in that call, we'll look at where your practice is now and what's actually holding it back, what kind of support you need, what makes sense for moving forward. And we've got a QR code here. We'll provide a link in the comments so you can find a time that to schedule this practice changing conversation.
And so I'd love to speak to you. I'd love to see, if digital would fit into your practice and how you can make that happen. And, if at some point you also want to create your own digital programs, we can definitely talk about that as well, because the goal is to get as much of, our genius out there as possible. So that is also something that, down the pike, after you have your digital arm kind of working, then we can start to think about developing your own digital programs as well, so you can really get all of your knowledge out there. So with that, we hope that this was helpful for you, and that you see that we can make vision therapy much more profitable than it is. We can help as many people as we want to, with no limit on that, and we can have your practices be successful. And so with that,
and still have a life.
Yes. Still have a life. So with that, let's get building. I hope to talk to you soon.